Welcome to this explainer. Today, we're diving into the ridiculously high-stakes world of therapeutic drug monitoring. We're talking clinical biochemistry and the incredibly dangerous tightrope of medical dosing. I mean, think about it. How do doctors know exactly how much medicine to give you? Well, it turns out, for some drugs, getting the dose wrong by just a microscopic fraction is literally the difference between a life-saving cure and a lethal poison. So let's kick things off with a pretty fundamental question. Why is it that taking an everyday painkiller like ibuprofen requires absolutely zero follow-up, but something like a seizure medication comes with a mandatory, non-stop ticket to the phlebotomist? What on earth is happening inside the body that demands such intense, constant surveillance? To solve this medical mystery, we'll be tackling this in 5 steps. First, finding the sweet spot. Second, the high-stakes drugs. Third, when TDM is actually useless. Fourth, inside the TDM workflow. And finally, from therapy to toxicology.
All right, let's jump right into Section 1, Finding the Sweet Spot, which is all about the biological balancing act.
The exact second a drug enters your bloodstream, it kicks off this massive journey of absorption, distribution, metabolism, and excretion. But the real magic? That only happens at a very specific concentration level. Think of it like a Goldilocks zone, what we formerly called the therapeutic window. This is that perfect, narrow range of drug concentration in your blood where the drug actually does its job without harming you. It's the sweet spot. But, as you might guess, this window has some pretty hard boundaries.
Let's look at the absolute floor of our Goldilocks zone first. This is the minimum effective concentration, or MEC. If the concentration in your blood drops below this level, the dosage is entirely subtherapeutic, meaning it's completely useless. The dose is just too low to do anything, and you get absolutely zero pharmacological benefit from it. On the flip side, we have our ceiling, the minimum toxic concentration, or MTC. If the drug builds up past this point, you cross a very dangerous, invisible line. You instantly go from receiving helpful therapy to experiencing serious dose-related adverse effects. The dose is now high enough to actively cause you harm. Which brings us to Section 2, the high-stakes drugs and walking the narrow index. Here's the thing. We don't monitor every drug. We only track the heavy hitters, the ones with what we call a narrow therapeutic index. For these specific drugs, a tiny, almost imperceptible change in dose can have devastating consequences. Take anti-epileptics like phenytoin. Toxicity there means central nervous system depression. Or heavy-duty antibiotics like gentamicin, where crossing the ceiling causes nephrotoxicity, meaning severe kidney damage, or ototoxicity, which is literally irreversible deafness. And for immunosuppressants like cyclosporin, a slight overdose damages the exact organs you're desperately trying to protect. To really put this into perspective, let's look at digoxin. It's a cardiovascular drug used for arrhythmias, and its optimum therapeutic range is a microscopic 0.8 to 2.0 micrograms per liter. If that level climbs to just over 2.5, we're talking a fraction of a single microgram more. It triggers severe gastrointestinal, cardiovascular, and neurological toxicity. It is a terrifyingly tiny tightrope to walk.
Moving right along to Section 3, when TDM is useless, and the exceptions to the rule.
So when is sending blood to the lab actually a complete waste of time? Well, if a drug is highly forgiving and has a wide therapeutic index, like your standard everyday NSAIDs, we don't need to monitor it. If toxicity isn't a realistic concern, like with penicillin, therapeutic drug monitoring is totally unnecessary. Plus, if a doctor can measure the drug's effect using simple, functional clinical tests, like just slacking a standard blood pressure cuff on you for antihypertensives, you really don't need a complex lab test to figure out if the medicine is working.
All right, Section 4, inside the TDM workflow, also known as the lab detective work.
For the drugs that absolutely do require monitoring, how do medical technologists track these invisible molecules floating around in your veins? It takes a massive amount of coordination. The workflow is this tremendously strict, unforgiving chain of events where timing is absolutely everything. It starts with the initial request, where noting the exact time of the last dose is crucial. Then comes the blood draw. Technologists have to decide if they're measuring trough levels, the absolute lowest concentration drawn right before the next dose, or peak levels, the highest concentration drawn shortly after administration. If a phlebotomist draws that blood even a few minutes off schedule, the entire lab result is completely meaningless. Once that perfectly timed sample hits the lab, the real analysis begins. Technologists usually have to weigh two options. They have to balance the sheer speed of immunoassays, which are fast and common but rely on antibodies and can sometimes give you false positive cross-reactivity, against liquid chromatography tandem mass spectrometry, or LC-MS. That one is the slow, highly complex gold standard that gives you an undeniable, exact molecular fingerprint of the drug.
But get this, before the machine even runs, there's this hidden, incredibly dangerous trap in the collection process called the gel warning. When drawing blood, if a phlebotomist uses a serum separator tube, the ones with that little layer of gel at the bottom, that gel can literally absorb certain drugs like phenytoin or digoxin right out of the blood sample. This spits out a fake, falsely low reading. A doctor might look at that result, think the patient needs more medicine, accidentally increase the dose, and send them straight into a catastrophic toxic overdose. Wild, right?
Finally, let's hit Section 5, from therapy to toxicology and crossing the line.
So how does this exact same lab workflow pivot from keeping patients in that therapeutic sweet spot to diagnosing outright poisonings? Well, it all goes back to the central dogma of toxicology, coined by Paracelsus. The dose makes the poison. Literally any substance can be a poison. Even massive quantities of water can be lethal. It completely blurs the line between what is a medicine and what is a poison. At the end of the day, it all comes down to the concentration level inside the body. When a drug crosses that critical line from therapeutic to toxic, clinical biochemistry leaps into action. Labs use urine for long window screening and blood for acute toxicity to see what's actively hitting the brain right now. They're screening for alcohols like methanol, whose toxic metabolites can cause permanent blindness. They're hunting for analgesics like acetaminophen, where an overdose leads to catastrophic hepatotoxicity or liver failure. And of course, they screen for drugs of abuse and heavy metals like lead and mercury, which actually require highly specialized atomic absorption testing.
While the lab is furiously running these tests, the clinical team on the floor is desperately looking for toxidromes, or toxic syndromes. For instance, if a patient presents with pinpoint pupils, respiratory depression, and bradycardia, a severely slowed heart rate, that's your classic toxidrome for an opioid overdose. But physical symptoms can be super misleading. The laboratory's the ultimate truth teller here. They are the ones confirming those clinical toxidromes and proving definitively whether those pinpoint pupils are from a simple neurological event or massive opioid toxicity.
But there's actually a pretty huge catch to this ultimate truth. In drug screening, a negative result doesn't always mean the drug is completely absent. It simply means the concentration of that drug is just below the specific cutoff level of the laboratory's assay. So, to wrap up this explainer, I want to leave you with a slightly unsettling thought about the true limits of our medical technology. If a negative screen just means the substance is below our machine's threshold to trigger an alarm, how many undetectable traces of toxins and medications might be flowing through our systems right now? It really makes you appreciate the incredible, invisible balancing act happening inside our bodies every single day.